Alrighty, officially welcome everyone to the National Myeloproliferative Neoplasms Conference. The Leukemia and Lymphoma Society of Canada is proud to introduce you to our first presentation of a series of 3 evolution therapies for myelofibrosis, from palliation to disease modification. In this 1-hour live webcast, Dr. Vikas Gupta, hematologist at the Princess Margaret Cancer Centre in Toronto, will review MF and the evolution and diagnosis, treatment options, and aspects of follow-up care. Before we begin, let me introduce myself. My name is Isabella Garafello, and I'm the Community Services Lead for Ontario West at the Leukemia and Lymphoma Society of Canada. I will be the moderator of this online event. We invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation. Due to the large number of participants and limited time, we may not be able to answer all the questions. Also note that Dr. Gupta cannot answer specific questions about a person's health, history, or status. Lastly, today's presentation will be recorded, therefore you can rewatch it again on our website. As we come together from across Canada, we recognize that we are on lands of many Indigenous nations. We honor the First Nations, Inuit, Métis people whose deep connections to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancers. Are you looking for specific programs or resources but not sure where to find them? We are here to help. You can connect with the community services lead in your area to receive personalized assistance and get connected to resources in your area. We can listen attentively and with compassion to the challenges you are facing, point you to information specific to your type of blood cancer or treatment, help you get organized to manage and take charge of your care, and identify services that would be beneficial to you. We know that having a diagnosis of myelofibrosis can be very overwhelming, but know that you are not alone. There is a blood cancer community that is here to support you every step of the way. As mentioned earlier, you can access one-on-one support to help you navigate the blood cancer experience. On our website, you will find tailored information and resources, including those specific to myelofibrosis. Our goal is to better serve the community and offer an improved experience. The information and resources on our website are tailored and presented in multimedia formats to address the variety of needs and preferences. This includes fact sheets and booklets like the ones you see on your screen, podcasts from our channel called The Blood Cancer Experience, and you can find hundreds of podcasts for people touched by blood cancer and many addressing challenges that people living with MF face. We speak to experts about current topics such as treatments, diagnosis, and research, and you will also hear personal stories from people touched by blood cancer. We have information and resources to watch, like previous webcasts and animated videos. To find those, visit bloodcancer.ca to read, listen, and watch all these great resources. Before introducing our speaker, we wanted to address an important situation for the MPN community, the Pegasys shortage. And to do that, we have invited Dr. Shireen Shirhan, hematologist at the Jewish General Hospital in Montreal and president of the Canadian MPN group, to address you in this short video. If you have any questions related to that situation, please contact your doctor, LLSC, or the Canadian MPN group. Now, just a few minutes for this video.
Hi everyone, I'm Dr. Shireen Sirhan. I'm president of the Canadian MPN group. I'm a hematologist and an MPN specialist at the Jewish General Hospital in Montreal, Canada. I know that the Pegasys shortage has been incredibly stressful, and I want to start by recognizing the strength of this community, both patients and physicians, who have come together to advocate for a solution. Your voices have been powerful, and I sincerely thank you for your patience and your persistence. Because of our collective effort, Health Canada has taken an unprecedented step. For the first time, they have approved an exceptional importation of Ropeg, which is not a Health Canada approved drug. This is in response to patient and physician advocacy. This decision reflects the impact of a united front, patient, physician, and pharma working together to ensure continued access to treatment. We have been working on several next steps to help navigate this transition. Some remaining Pegasys supply, approximately 60%, is still available and is being redistributed across provinces to ensure fair access. A guidance letter has been prepared to help physicians make informed decisions on Pegasys use. Meetings with provincial authorities are planned to determine how ROPEG will be reimbursed and distributed, and we expect updates shortly. We will then issue a guidance document addressing the safest way to transition patients from Pegasys to ROPEG. I also want to take a moment to acknowledge the dedication of my colleague physicians across the country. Many of you have gone above and beyond, advocating for patients, adapting to challenges, and working through uncertainty. This progress would not have been possible without your efforts. I also want to thank Forest Health for their critical support in ensuring a rapid supply chain of ROPEG and for helping amplify our advocacy. There is still work ahead, but we are making progress. Thank you for your trust, your patience, and your continued advocacy.
Wonderful. It is now time to introduce today's speaker, Dr. Vikas Gupta. Dr. Gupta is multidisciplinary clinical lead of the Leukemia program at Princess Margaret Cancer Centre and director of the Elizabeth and Tony Comfort MPN program. He holds the Barbara Baker Chair in Leukemia and Related Disorders at the University Health Network. His clinical and research activities are focused on developing novel transplant and non-transplant-based treatment strategies for patients with myeloproliferative neoplasms, or MPN. He is the founding member and past president of the Canadian MPN Group. The MPN program at the Princess Margaret Centre acts as a national resource for the care of complex patients with MPN. The MPN program offers short and long-term skills building opportunities for fellowship training, training of community hematologists and oncologists, and other healthcare providers. Thank you for being with us today, Dr. Gupta.
So thank you very much for inviting me, and I'm honored to present at this meeting. Do I have the control? Okay, so over the next 40 minutes or so, I'm going to briefly talk about evolution of therapies for myelofibrosis and the progress we have made from starting with palliative therapies to upcoming investigational therapies, which we hope will be sort of, pivotal in disease modification for myelofibrosis as well as other related myeloproliferative neoplasms. So these are my disclosures. So, I mean, this audience is very familiar with the natural history of myeloproliferative neoplasm. To put things in context, essential thrombocythemia, polycythemia vera, and myelofibrosis are the three classical Philadelphia negative myeloproliferative neoplasms. Myelofibrosis can present as a primary disorder, or patients with essential thrombocythemia and polycythemia vera over a period of time, disease can progress to myelofibrosis. And all these three classical disorder have the risk of disease transforming into blast phase, also known as acute myeloid leukemia. In my presentation, I will use the word myelofibrosis, which will represent both primary and secondary myelofibrosis, secondary to essential thrombocythemia or polycythemia vera. So these are the objectives of my talk. I'm going to briefly talk about benefits and limitation of current approved JAK inhibitor therapies in myelofibrosis. I would spend some time in discussing about identifying the pattern of JAK inhibitor failure and its implication in myelofibrosis. And I will sort of, in the end, sort of, briefly review what are the novel therapies which are on horizon for myelofibrosis. So first, about clinical manifestations of myelofibrosis. No two patients with myelofibrosis are similar. Patient can present with a variety of symptoms, and these symptoms could be particularly related to, can be sort of, categorized into three main categories: symptom related to anemia or low hemoglobin, symptom related to enlarged spleen, and constitutional symptom. When we use the word constitutional symptom, it's meant as symptoms of fever, night sweats, or weight loss. A given patient can have combination of this symptom, or can have more symptom in one domain. In addition to these symptoms, patient can have symptoms related to bleeding manifestation, thrombotic complication, other symptoms such as bone pain, increased risk of infection, symptoms of itching. And this is another way to look at the symptom burden of patients with the three classical myeloproliferative neoplasm. As you will see that fatigue is one of the most common symptom experienced by patients with myeloproliferative neoplasm, and patients with myelofibrosis have somewhat sort of, more symptom burden, particularly in symptom related to splenomegaly, although sort of symptom burden continues to remain high in patients with myeloproliferative neoplasm, irrespective whether we're talking about ET, polycythemia vera, or myelofibrosis. This is a study which we did in Ontario. In Ontario, we have an administrative database which sort of, collects all the information how various patients are using healthcare resources. So in this, we compared the healthcare resource utilization of patients with ET, PV, and myelofibrosis, and we compared it to the age, sex, and socioeconomic status, sort of, matched for various parameters in the control population. And as you will see that patient with myelofibrosis not only use acute resources, but there is an increased healthcare resource utilization in various ways, attending more emergency room, using specialist, general practitioner. So healthcare resource utilization of patients with ET, PV, and myelofibrosis is significantly higher compared to control population. And among the various myeloproliferative neoplasm, healthcare resource utilization appeared to be higher in patients with myelofibrosis. And this is not surprising, given that patients with myelofibrosis have increased symptom burden as well as other related complications compared to PV and ET patients. Now, the field of myeloproliferative neoplasm was revolutionized with the discovery of JAK2 mutation. And shortly after the JAK2 mutation, another mutation called MPL mutation was found. And about 11 years back, a third mutation, which was found in JAK2 negative patient called calreticulin mutation. Now, these three mutations are called MPN driver mutations, and these mutations are present in more than 90% of the cases with myeloproliferative neoplasm. JAK2 mutation is present in 95% patients with PV. In myelofibrosis and essential thrombocythemia, JAK2 mutation is present in about 50 to 60% of the patient. And patients who are JAK2 negative, CALR mutation is the second most commonly found mutation in patients with essential thrombocythemia and myelofibrosis. And then MPL mutation, which is seen in about 5 to 7% of the cases. Approximately 10% of myelofibrosis and ET patient at present, we don't know a driver mutation, and these patients are also known as triple negative patients. In addition to these three MPN driver mutations, there has been increased recognition of other mutations which are common in all myeloid malignancies, including myeloproliferative neoplasm, other related disorders such as myelodysplastic syndrome or acute myeloid leukemia. At Princess Margaret, we started using next generation sequencing, a panel to identify these additional mutations in 2015. And this was our initial experience, which was published in a peer-reviewed publication. And presence of those mutations now is integrated in some of the new prognostic scores. So in 2009 and 2010, the initial prognostic score such as IPSS, DIPSS were described. And more recently, particularly in the last 8 to 10 years, there has been integration of molecular information into these risk score and new risk scores, which are called MIP70 or MIP70 plus scores. They are being increasingly used in clinical practice, and you might have heard about this score during your interaction with your physician while discussing your case. Now, increasingly, there are a huge number of scores, now prognostic scores available, and this is a recent publication in one of the leading journal, which describe various scores, when to use which kind of score, and depending upon the information available in any particular scenario for patients with all three classical myeloproliferative neoplasms. Our group's own interest has been developed in the development of gene expression scores in patients with myelofibrosis. And this is some of our earlier data, which is available on the internet. And what we have been able to do is that adding gene expression score to current scoring system, we are able to identify the disease behavior in a more precise manner. This is still in research and not available in the routine clinical work, but we are working on a clinical test which can be easily implemented in the routine clinical management of myelofibrosis. We hope that in 6 months' time, we will have this test available to patients with myelofibrosis. Options for myelofibrosis are guided by symptoms as well as risk score of the patient. So patients who are considered higher risk and if in the transplant age group, those are the patients who are considered candidate for transplantation, and patients who are not candidate for transplantation or who have have symptomatic disease. By symptom mean symptom related to splenomegaly or constitutional symptom are considered candidates for non-transplant therapy, which predominantly in today's day and age is JAK inhibitor therapy for majority of patients. I'm going to mainly talk about JAK inhibitor therapy and newer drugs, but I just want to mention a couple of slides about the transplantation. In transplantation, the role of transplantation in management of myelofibrosis is well established. More recently, there has been increased use of haplotransplant in patients with myelofibrosis, particularly patients from ethnic minorities who may not have a matched donor because unrelated and these matched the donors in the ethnic minorities are not well represented in the unrelated donor registries. So there has been slow progressive improvement in outcome of transplant in patients with myelofibrosis. On the left, there is a study which we did through Center for International Blood and Marrow Transplant Research. And this study was published approximately 10 years ago. And in this study, you will see that the outcome of matched sibling donor transplant is significantly better compared to well-matched unrelated donor transplant, but patient who had partially matched or mismatched unrelated donor, their outcome was significantly inferior. Now, on the right side, this is a study which we again did through CIBMTR and has been published recently. And in this study, you will see that over the last 10 years or so, the outcome of, so particularly there has been slow gradual improvement in outcome of donors which are not matched donors, and particularly the outcomes of haplotransplant has been encouraging. So this gives a option of transplantation to the patient who don't have matched donor, and is a particular useful modality when you need transplant in patients from ethnic minorities. Now, I'm going to spend next 25 minutes or so discussing about JAK inhibitor therapy. As I mentioned, one of the game changer in field of myeloproliferative neoplasm was the discovery of JAK2 mutation. Shortly after the discovery of JAK2 mutation, there was clinical trials were developed using JAK inhibitor therapy. At present, there are 4 JAK inhibitors: ruxolitinib, fedratinib, pacritinib, and momelotinib, which are FDA approved. In Canada, we have 3 JAK inhibitors which are Health Canada approved: ruxolitinib, fedratinib, and momelotinib. Pacritinib at present is not Health Canada approved. The clinical development of other JAK inhibitors have been by and large put on hold, as those JAK inhibitors did not present any additional benefit over currently available JAK inhibitor or had unacceptable toxicities. So first, talking about ruxolitinib. Ruxolitinib was clinical trials with ruxolitinib started in 2007, and ruxolitinib was the first-in-class JAK inhibitor approved in 2011 by FDA and 2012 by Health Canada. And this JAK inhibitor was a game changer at a time when we did not have any treatment options for patients with myelofibrosis. And as you will see that ruxolitinib treatment with ruxolitinib resulted in not only rapid reduction in the spleen size, but also it helped in overcoming the symptoms related with cachexia. If you note in this picture, there is on the left side, there is a lot of muscle wasting, and you would see identify from the space between the rib cage, and patients, once they start on ruxolitinib, they start overcoming this problem of ruxolitinib associated cachexia. And the pivotal trial which led to approval of ruxolitinib was COMFORT-1 and COMFORT-2 trial, where ruxolitinib was compared to placebo, or ruxolitinib was compared to best available treatment. And at that time, best available treatment for majority of patients was hydroxyurea. Now, this is a summary slide of pivotal clinical trial for all the 4 JAK inhibitors which have been FDA approved. And as you will see, among these various JAK inhibitors, the only JAK inhibitor where one JAK inhibitor has been compared as a head-to-head comparison is momelotinib, which was compared to ruxolitinib in a randomized control fashion. All other JAK inhibitors have been compared to placebo or best available treatment. And this summary slide shows that all 4 JAK inhibitors have benefit in reduction of splenomegaly. In addition, all 4 JAK inhibitors have a similar benefit on reducing the symptoms of the disease. So what is different about these 4 JAK inhibitors? So one of the major side effect of these JAK inhibitor is, especially ruxolitinib, fedratinib, is anemia and thrombocytopenia, which is present in a significant number of patients. Now, if you see in simplified trial where momelotinib was compared to ruxolitinib, the grade 3/4 anemia is significantly lower in comparison to ruxolitinib. So anemia toxicity in momelotinib was lower, and also in trials which compared pacritinib with best available treatment, the pacritinib seemed to be better tolerated in patients with myelofibrosis who had low platelet count in comparison to best available treatment. Now, the question comes that all these drugs are JAK inhibitors, so why they have like different side effect profile? So as I mentioned that the beneficial effect of anemia, a beneficial effect on spleen and symptom among these JAK inhibitor is somewhat very similar, but the toxicity profile of JAK inhibitor could be somewhat different. Now, ruxolitinib is a JAK1, JAK2 inhibitor. Fedratinib primarily inhibits JAK2, but it also inhibit is also inhibitor of FLT3, and FLT3 inhibition leads to some of the side effects particularly experienced by fedratinib treated patients, such as gastrointestinal side effect, nausea, vomiting, or diarrhea. Momelotinib, in addition to JAK1, JAK2 inhibitor, is a ACVR1 inhibitor, which is thought to be sort of, particularly important in anemia benefit and decreased anemia toxicity. And pacritinib, in addition to JAK2 inhibition, is a IRAK1 inhibitor, which makes this medication better tolerated in thrombocytopenic patients. So I mentioned about the beneficial effect of JAK inhibitor therapy, the limitation of JAK inhibitor therapy. These limitations are very similar to currently available all the 4 FDA JAK inhibitor, but they are better studied with ruxolitinib because ruxolitinib has been in use since 2011. No, none of the JAK inhibitor are considered curative. They are mainly used to control the symptom of the disease. They do not reduce the disease or the cancer clone significantly. As I said, mentioned that JAK inhibitor, one of the major side effects of ruxolitinib is anemia or thrombocytopenia. Other JAK inhibitor have variable effect on cytopenias. Patient treated with JAK inhibitor have increased risk of atypical infections such as tuberculosis, reactivation of hepatitis, or other infections. JAK inhibitor do not reduce the risk of myelofibrosis transforming into acute leukemia, and JAK inhibitor therapy does not work forever. There are significant rates of discontinuation of JAK inhibitor therapy, and there is no convincing effect that JAK inhibitor therapy leads to resolution of bone marrow fibrosis. No, this is a data from COMFORT-2 trial where the investigators looked at a reduction in JAK2 allele burden in patients with myelofibrosis, and the activity, the allele burden reduction in myelofibrosis patient is very modest, and less than 20% of patients had more than 20% reduction in JAK2 allele burden. On the right side, there's data from Princess Margaret, where we looked at what is the incidence of JAK inhibitor failure, and in our own hand, approximately 50% of the patient who start JAK inhibitor therapy will come off fail JAK inhibitor therapy by 2 years on the treatment. In clinical trial, usually this experience is patient fail around sort of 3-year mark. In real life, most of the patient will tolerate JAK inhibitor for 1 to 2 years. And the reason for that is in clinical patients who are treated on clinical trial usually will have a better organ function, better performance status, and in real life we are treating patients with sort of all sorts of other comorbid conditions. Now, how do we identify what are the various ways a patient can fail ruxolitinib therapy? As I mentioned, that this pattern of JAK inhibitor failure is very similar across all the JAK inhibitor. It is better studied in patient with ruxolitinib. Now, a patient can fail ruxolitinib. Either patient can have a sort of does not have adequate spleen response, what we also call as suboptimal spleen response, or patient had a good response to spleen, but after some time start losing the response to spleen or symptom. Patient can develop anemia or thrombocytopenia on JAK inhibitor therapy, which further sometimes can cause a reduction in the dosages of JAK inhibitor therapy, and which leads to sort of loss of control on the spleen. Or some patient on ruxolitinib therapy can develop sort of accelerated phase or blast phase of the disease, where there is an increasing number of blasts in the peripheral blood. These patients develop AML type of picture. So when somebody who's not doing well on JAK inhibitor therapy or ruxolitinib, we first try to sort of figure out why they are not doing well on JAK inhibitor. Is it because their disease is progressing towards accelerated phase or blast phase? And if it is, then those patients need more like a acute leukemia type of treatment strategy. Patient who develop anemia on JAK inhibitor therapy or ruxolitinib therapy, the options for those patients are erythropoietin injection or danazol treatment. More recently, the option of momelotinib has become available, and there is a clinical trials which have been conducted. Use of luspatercept. Luspatercept is an approved drug in patients who have anemia related to myelodysplastic syndrome. This drug is not approved for patients with myelofibrosis, but there are clinical trials which have been conducted with luspatercept. We are waiting for the result of phase 3 trials in patients with myelofibrosis. I'm going to talk briefly about it. And at Princess Margaret, we also have an upcoming trial which will be using combination of momelotinib and luspatercept in patients who have anemia associated with myelofibrosis. Patients who have suboptimal spleen response or have initial spleen response but lose spleen response, the option could be either switching JAK inhibitor therapy to another JAK inhibitor called fedratinib, which is available in Canada, or add on an investigation trial available. If patient is CALR mutated, we add CALR antibody treatment as a part of clinical trial, or BET inhibitor as a part of clinical trial. There are several other trial available. I just mentioned a couple of them which are available at Princess Margaret. Now, let's first talk about fedratinib. Fedratinib is both FDA Health Canada approved medication. It is approved in Canada for both for first and second line treatment, but the funding is mainly for second line treatment for patients who develop anemia or thrombocytopenia on ruxolitinib therapy. And this is a randomized trial where fedratinib has been compared to best available treatment. And even in the second line setting, fedratinib appears to have a good response to spleen volume reduction in patients with myelofibrosis who are not doing well on ruxolitinib therapy. Now, I'm going to briefly talk about some of the emerging treatment which have the potential to address some of the unmet medical needs in patients with myelofibrosis. As I mentioned, that momelotinib is now Health Canada approved. Momelotinib was compared with ruxolitinib in Simplify-1 in patients who did not have any exposure to JAK inhibitor therapy before. And there has been 2 randomized trials done in Simplify-2 and Momentum trial, which enrolled patients who were previously treated with ruxolitinib therapy and had significant issues related to ruxolitinib. Pacritinib, there have been 2 randomized trials done, Persist-1 and Persist-2. Persist-1 trial, pacritinib was compared to best available treatment, which was mainly placebo in a randomized controlled fashion. In Persist-2, this trial was done in thrombocytopenic patient, and pacritinib was again compared to best available treatment, which included ruxolitinib in patients who had platelet count more than 50. There is an ongoing trial, Pacifica, which is enrolling patients who have thrombocytopenia with on ruxolitinib therapy, or patient who start with, who at the time of presentation had platelet count less than 50. This is a randomized trial where patients are randomized between in a 2:1 fashion to receive pacritinib versus best available treatment. And there are several combination therapy trials which have been conducted. I'm going to briefly talk about these trials. So first about Simplify-2 trial about momelotinib. As I mentioned that in Simplify-2 enrolled patient population which had been previously exposed to ruxolitinib, and compared to best available treatment, the patient who were treated with momelotinib, their red cell transfusion rates at week 24 were significantly lower in comparison to best available treatment. There was increased proportion of patients who were transfusion independent and decreased proportion of patients who were transfusion dependent by using momelotinib in comparison to best available treatment. Again, the same thing was replicated in Momentum trial where patient momelotinib was compared to danazol, and there is a significant higher proportion of patients who were red cell transfusion independent treated with momelotinib in comparison to danazol. And on the right side, the graph shows that patients who were on momelotinib, their hemoglobin level were much higher than danazol. And when danazol patients were crossover to receive momelotinib, their hemoglobin, that led to improvement in the hemoglobin level. Now, some patient on ruxolitinib can develop sort of significant amount of bleeding or bruising associated with thrombocytopenia. And as I mentioned, that pacritinib has been previously tested against best available treatment and shown to have significant improvement in spleen as well as symptom burden, and was better tolerated in thrombocytopenic patient. In Canada, we do not have access to pacritinib at present. Only access at present for pacritinib is through Pacifica trial, which I mentioned as a randomized controlled trial, enrolling 2:1 fashion to pacritinib versus physician choice best available treatment. So what are the various disease modifying therapies? So as I mentioned, JAK inhibitor therapies are not considered curative therapy. So there has been quest to find other non-JAK inhibitor therapies which can get combined with JAK inhibitor to see whether that leads to improvement in the not only in the spleen and symptom, but other parameters which are associated with disease modification. So this is a clinical trial which has been presented at various meetings. This is called Manifest-2 trial, where pelabresib has been combined with ruxolitinib versus ruxolitinib plus placebo. And the treatment with combination therapy led to better spleen response in a combination therapy of ruxolitinib and pelabresib. The spleen responses were almost double compared to patients who received ruxolitinib plus placebo. However, this trial did not show any significant difference in the symptom burden response of combination therapy of ruxolitinib and with pelabresib versus ruxolitinib and placebo. Similarly, there was another novel agent called navitoclax, which was combined with ruxolitinib in a trial called Transform-1. And again, the findings were very much similar to what we saw in Manifest-2 trial. The spleen volume response was double in this trial. But again, similar to pelabresib, there was no significant difference in the symptom burden treated with patient who received combination therapy versus ruxolitinib and placebo. Now, luspatercept, as I mentioned, approved for myelodysplastic syndrome patient This is the result of phase 1, phase 2 study where luspatercept showed encouraging activity in patients with myelofibrosis as a monotherapy, as well as in combination with ruxolitinib therapy. And there are a clinical trial called Independence Trial has finished enrollment, and we are hoping that in about 6 to 8 months we will have the first readout of the result of this Independence Trial. Here patient have been this is a randomized controlled trial where patient who develop anemia on ruxolitinib has been randomized to receive luspatercept versus placebo. And the result of this trial is awaited whether this could be another option for patients who develop anemia on JAK inhibitor therapy. Now, one of the exciting development in the field of myeloproliferative neoplasm more recently had been development of targeted therapy. Calreticulin mutation, which was discovered in 2014, and some properties of calreticulin mutation, such as expression of calreticulin on the cell surface, mutant calreticulin on the cell surface, make it a very attractive target for immunotherapy approaches. And the clinical trial, there has been significant preclinical work done to develop immunotherapy approaches for CALR mutated patients. There are 2 clinical trials which has been sort of in progress. Both trials are available at Princess Margaret. There's a first trial is a monoclonal antibody trial, which is used as either monotherapy or in combination with ruxolitinib therapy in patients with myelofibrosis. And in patients with ET also, this is being investigated in patients who have hydroxyurea intolerant or resistant ET. There is a bispecific T cell antibody, which trial is also in progress and available at Princess Margaret. Bispecific antibodies have been game changer in the field of acute leukemia, lymphoma, multiple myeloma, and these bispecific antibody has been very successful treatment for various blood cancers. So we are hoping that in CALR mutated patient, this may become an option in the future. Early to say whether this will, it's a little bit early to say the efficacy of these agents, but the trials are in progress. Now, there has been a lot of interest in developing CAR-T treatment. CAR-T, as you guys know, that it's a successful treatment for patients with various types of lymphoma, multiple myeloma, acute lymphoblastic leukemia. Again, there has been significant work accomplished to develop CAR-T in preclinical models for CAR-T mutated, CALR mutated MPN patient. However, the human trials have not started yet, but this could be another option which may become available in the near future. This is just to show some preclinical work which was done with CALR monoclonal antibody, and this is from a mouse model where treatment with CALR monoclonal antibody led to resolution of fibrosis as well as reduction in the megakaryocyte count in the patient-derived xenografts. No, this is the first patient on the CALR bispecific antibody, which was enrolled at Princess Margaret, and as I mentioned, these trials are available, and various antibody trials are available at Princess Margaret. So I'm going to stop here. I would like to acknowledge that some of the data from Princess Margaret I presented is a sort of our teamwork with my colleagues, particularly Don Mays, Hassan Sibai, Aniket Banker, Marta Davidson, our fellows, and our collaborators in the Canadian MPN group and the laboratory staff. So I'll stop here and happy to take some questions.
Wonderful. Thank you, Dr. Gupta, for sharing your expertise and insight with all of us. As mentioned, it's now time for our question and answer period. If you haven't done so already, be sure to use the Q&A box in your Zoom webinar panel just down below to type your questions. As we mentioned earlier, due to the large number of participants and limited time, we may not be able to answer all questions. And also note a reminder that Dr. Gupta cannot answer specific questions about a person's health history or status. So to kick us off, Dr. Gupta, for someone that is diagnosed as pre-myelofibrosis, is there any possibility that Jakafi or other treatments can reverse and bring it to remission, as it seems like US doctors prescribe it?
Yeah. Jakafi for prefibrotic myelofibrosis, we use Jakafi or any JAK inhibitor therapy primarily to deal with the symptoms of the disease. And by symptom mean symptoms such as symptom related to splenomegaly or symptoms such as fever, night sweat, weight loss. We have now many years of experience that there is no sort of, these are not necessarily, there has not been any study which has shown benefit of using it in sort of, pre-fibrotic myelofibrosis as a mean to prevent the progression of the disease. There is a lot of interest in developing new medication for pre-fibrotic myelofibrosis, but particularly focusing on preventing the progression of the disease. And at our center in the future, there will be an interferon trial will become available for pre-fibrotic myelofibrosis patient as the progress for the CALR antibody trial moves further. There is a possibility these drugs will be tried in patients with who have CALR mutated prefibrotic myelofibrosis. There is also sort of, more recently, there are JAK2 mutation targeted drug, like the current JAK inhibitor therapy, they act on dysregulated JAK-STAT pathway. They don't type 2 JAK inhibitor, which are entering human clinical trials. And if those trials are successful, perhaps those will be the medication better to try in prefibrotic myelofibrosis setting once we have more data on safety and efficacy available with those investigational drugs. So to answer your question, we don't use Jakafi to prevent progression because there's no convincing evidence that treatment with Jakafi prevents the progression of prefibrotic myelofibrosis.
Thank you. We have another question as well. Why would a doctor prefer prescribing hydroxyurea over a JAK inhibitor?
There could be some specific circumstances which may be sort of, there may be some patient may not have symptom related to splenomegaly or constitutional symptom, and patient may have just high white blood count or high platelet count. So it will depend on individual circumstances. So it will be perhaps much better to discuss the individual circumstances with your physician.
Wonderful, thank you. Another question, what are the probabilities that two members of the same family have the same JAK2 mutation?
Very low, but there have been cases, sort of, clusters. We have several sort of, perhaps I would say half a dozen families in our program where more than two members sort of, have been affected with myeloproliferative neoplasm. Familiar occurrence of myeloproliferative neoplasm is well known. Is it common? The answer is no. Can it happen? The answer is yes. We have several sort of, families in our clinic where more than two members have been affected with the JAK2 mutation, even with the CALR mutation.
Thank you. Someone also wants to know, could the JAK2 mutation be triggered by an external factor?
It is possible because these mutations are acquired many years prior to they become sort of disease or become prominent. And at present, we don't exactly know what was the trigger factor. So there could be sort of um, external factor, exposure to radiation therapy, exposure to chemicals, all those are possibilities which can act as a trigger factor for this mutation. The problem is that at present, we do not know what was the trigger factor, but it's quite possible it is external factor do play a role in triggering JAK2 mutation.
Thank you. Someone also asked, when anemia is the only symptom and a transplant has been approved, would you suggest going directly to the transplant or going on momelotinib prior to the transplant? Is it best to delay a transplant due to the high risk of the procedure?
Yeah, I think this is a you cannot have a general answer to this question. So it it has to be very carefully reviewed. What are sort of your risk score and other symptoms, etc. So I think it's a question which you need to discuss with your physician, your individual circumstances with your physician, to going through that in detail. Uh, it, it's something which cannot sort of one size fit all approach can be used in all the patients. So each patient's individual circumstance, depending on your individual circumstances, the approach has to be individualized, whether it is beneficial to move to transplant early or delay the transplant.
Thank you. And someone also wants to know, can you explain about immune therapy? How does it work?
So immune therapy, so let's first talk about, I think the immune therapies which we have in myeloproliferative neoplasm at present are for CALR mutated patient. As I mentioned, there are two types of immune therapies which are available as a part of clinical trial. One is monoclonal antibody. Basically, it goes and binds to the mutated sort of CALR cancer cells and does the killing of those cells. The second type of antibody is called what we call as bispecific antibody. So if you think about bispecific antibody, it's an antibody which has sort of two arms. So on one arm, sort of binds to the T cells. T cells are the immune cells in the body, and T cells are help in clearing cancer infection from the body. And what this bispecific antibody does is, on one hand, it binds to the cancer cells. On second hand, it binds to the T cells, and it brings sort of T cells near to the cancer cells, which result in the killing of those cancer cells. So these are called bispecific antibody or bispecific T cell engager antibody, where it brings T cells near to the cancer cells to result in cancer killing.
Wonderful. Thank you so much, Dr. Gupta, for your time today. Your expertise is very valuable to us. That looks like the bulk of our Q&A questions. And again, if something wasn't answered, please don't hesitate to reach out to your community services lead, or hopefully we answered it already. So yes, thank you again, Dr. Gupta, for your time today. Join us for the other sessions on the National MPN Week. So tomorrow, February 26th at 1 p.m. Eastern Time, for the presentation on understanding essential thrombocythemia, there we go, diagnosis, treatments, and follow-up care with Dr. Linda Foltz. And then on Thursday, February 27th at 1 p.m. Eastern Time, understanding polycythemia vera, or PV, diagnosis, treatments, and follow-up care with Dr. Sarkozy. We would also like to take a moment to thank Forest Therapeutics, Pharma, Essentia, and GSK for their support in making this event possible. And please remember that we are here to help you. You can reach us by email, by visiting our website, bloodcancers.ca, or by calling us toll free. Please note that a short survey will be sent to all participants after this presentation, and please take a moment to respond as it helps us plan future events. Thank you for being with us today, and take good care of yourself. Thanks, everyone.
Thank you very much.